Go. All right, so our project is over ventilated associated pneumonia, or VAP, and my name is Christina Kroll.
I'm Sadie Austin.
I'm Tess Ferris.
Okay, so what is ventilator associated pneumonia? Ventilators are essential for the survival of many patients who either have no intrinsic drive to breathe or have severe shortness of breath. It delivers high concentrations of oxygen to the lungs and removes excess carbon dioxide while decreasing the energy exertion of the patient so that they can recover. This form of intervention does not in itself fix the problem, but rather it supports the patient as other interventions become effective. The ventilator is used for as long as is necessary, and as Tobin and Manthos explained, it depends on the health of the lungs or other organs before it was initiated. Some patients will never recover. The role of the nurse is in management of the potential complications that can arise from ventilator use, specifically pneumonia prevention, including proper positioning, suction and oral care, and sterile procedures. VAP occurs because the body's defenses to fight against infection are compromised by intubation, allowing oral and gastric secretions to enter the lower airway. So, the infection risk is not definite, but according to the journal Infection Control and Hospital Epidemiology, the infection rate for ventilator-associated pneumonia is 10 to 20% of ventilated patients, and the mortality rate is approximately 10%. The statistics from Hill's article relating to the pediatric population has ventilated patients developing pneumonia at 29%. Another resource that we had from Evans marked that the incident of ventilator-associated pneumonia is about 25% of patients in the ICU. So our PICO question is, in intubation, how does the VAP bundle compare to non-checklist interventions affect ventilator-associated pneumonia within the hospital stay in the intensive care unit? So nurses have an important role in the prevention of VAP, particularly because of their constant presence at the bedside of ventilated patients. So the PICO question is relevant for every nurse taking care of a ventilated patient in the ICU. Should be asking yourself that question every time you take care of these patients. So $40,000, pretty big number. That is what the average cost of VAP is, over and above the already acquired hospital bill. So the cost of an already expensive hospital stay can increase by $11,000 to $50,000 within incidents of VAP. This hospital-acquired infection greatly affects the amount of time that the patient remains on mechanical ventilation and subsequently decreases the availability of beds. If your patient can't breathe on their own and then they get an infection, they're still not able to breathe on their own, which means they're not coming off that ventilator. The medical cost for preventable infections can impact the hospital if inadequate interventions were taken. So a lot of hospitals will end up fined or end up having to cover the extraneous cost if they are not taking the measures needed for the patients to not end up with pneumonia. So this video that we have is just giving a little bit of a visual explanation of kind of what I just mentioned and some things that Sadie and Tess will be talking about, how to take care of your ventilated patients and decrease the risk for pneumonia.
So now that you have a little background on the interventions, I'm going to elaborate on them and what we found in our research. So, according to an article from 2013 by Sarah Evans from the Nursing Critical Care Journal, to reduce the incidences of VAP, the Institute for Healthcare Improvement, known as IHI, introduced a preventative bundle of cares which, when performed together, reduce occurrences of VAP. Then the CDC limits their suggested interventions to only four, and they released a similar bundle the same year in 2004. The VAP bundle from the IHI includes DVT prophylaxis, which includes early ambulation, compression stockings, intermittent compression devices, and pharmacological prophylaxis, which would be a medication like heparin. They recommend a daily sedation vacation to be performed daily, which is when you turn off the sedation and then wait until the patient fully awakens and the mental status can be determined. Stress ulcer prophylaxis via medications, semi-recumbent positioning of at least 30 degrees, and oral care with chlorhexidine, which that point was added in 2010, and there's no decision on the optimal frequency of the chlorhexidine washes, whether that be daily or several times throughout the day. The CDC also recommended its own VAT bundle in 2004, and included in that is a more condensed version that would be raising the head of bed 30 to 45 degrees, continuous removal of subglottic secretions, so suctioning, changing the ventilator circuit only when it's visibly soiled or malfunctioning, and then making sure that healthcare workers perform hand hygiene. Both of these bundles were created for VAT prevention. There are also other evidence based recommendations we found in our research which can be used alone, and those include chlorhexidine rinses, gels, or swabs. And Evans says that the incidence of VAP has been significantly reduced with the use of oral antiseptics such as chlorhexidine during oral care. And then another point that we found is that the use of non invasive mechanical ventilation should be used whenever possible instead of um, a normal ventilator. And that would include a BiPAP and CPAP machine. So, according to the article by Evans, patients can also take preventative measures before even being admitted to the hospital, and that would be by getting their influenza vaccination. Obesity and malnourishment are also associated with an increased risk for pneumonia, and so maintaining an optimal nutrition status can be key as well.
So nursing interventions, we incorporate a few recommendations into nursing care and practice for the client. So daily assessment of ventilation and sedation weaning, regular oral care like we were able to see in that video, suctioning, stress ulcer prophylaxis, aid in prevention of bacterial overgrowth, and reducing the risk of infection, and then positioning the head of the bed raised and encouraging mobility whenever possible. So all of those things were mentioned with Sadie's slide in the EBP recommendations.
When we were doing our research, we recognized that a major issue that allows VAP to occur is the lack of nursing compliance with these interventions that we mentioned. And in her article from 2013, Evans says that nursing compliance is an issue that can contribute to the incidence of VAP. Novice nurses, along with experienced nurses who are transferring from different departments to work in ICUs, they need ongoing education to understand and follow through with proper preventive measures to reduce VAP incidence. Even experienced ICU nurses need reinforcement and continuing education related to VAP bundles, infection control policies, and all other aspects of VAP prevention. Staffing ratios may also play a role in nursing compliance with VAP prevention protocols. Staffing levels in the ICU must be sufficient to enable the nursing staff to provide optimal care for their patients, including compliance with all VAP prevention strategies. Many hospitals have transitioned to electronic medical records, and through EMRs, dashboard bundles can be created either prescribed by healthcare providers or as part of protocols. The dashboard systems remind the nursing staff, either daily or however the institution wishes, to perform VAT prevention care. Dashboards may improve compliance with an institution's ventilator bundle and VAT prevention by providing a visual reminder to staff and allowing real time review of compliance.
Wait, so we wanted to see what hospitals are currently doing. So we wanted to do a national hospital. So the first one is the Mayo Clinic, and they recommended to elevate the head of the bed. They want them to be in a semi-recumbent position. And then we want to do that sedation vacation like we talked about earlier. So we want to interrupt their sedation daily, make sure that they are coming to be fully awake so we can assess their neurostatus. And then we also want to see them try to wean them daily to try to get them to come off the vent because that's our goal because coming off the vent would ultimately prevent VAT from happening altogether. And then we also want to apply the prophylactis for the deep vein thrombosis. So, your SCDs, doing your range of motion, things like that. And then we want to also prevent peptic ulcers. So, doing prophylaxis for that with medications. And then, according to Berger and Razar, um, from their article, we found that the rate of VAT per 1,000 ventilator days decreased from 6 to 0.72 when they implemented the ventilator bundle. And then for my hospital that I work at Bergen Mercy, I was able to look in their policies and I wasn't able to find a BAP related bundle. They only had individual policy related to oral care and suctioning. So they did it, their policy stated to do it every 2 hours, and um, that isn't enough, we believe, for them to make sure that they are doing the best they can to prevent that from happening. So we wanted to try to give them some ideas of how to start to implement the VAT bundle. And our main takeaway from this, so keep this in your mind as I'm explaining what we think should be implemented, is education is always key for this. So first, we are going to want to start an organization committee. Um, at the facility, we're going to want that committee to gather the educational material for the floors, and then that committee will then distribute the information to the floors to the charge nurse will receive it first, and then that charge nurse will then take that material, receive the training on the VAT bundle, and then they will then go individually to their staff and teach them, because personally for me, I feel like I don't learn anything from the educational modules on the computer that we're required to do. I feel like if I'm in person and learning from my charge nurse, I will be able to put that into my brain and make sure that it's sticking rather than going through a module. And so after the charge nurse goes and trains the staff, they will then have to be checked off by the charge nurse to make sure that they are able to do the VAT bundle correctly. And then after that, we want to make sure that the compliance rate is 100%, or if not 100%, as close to that as possible. So we'll make sure that they're going to be doing audits to make sure that nurses are doing their VAT bundle, because ultimately, if our nurses are doing that, then hospitals will be saving a lot of money and we will have better outcomes for our patients. And then to make sure that we are being compliant and that this is fresh in our minds all the time, we want to make sure that they're doing yearly checkoffs. And then, according to Evans, our article stated that across the country, VAP, although preventable, costs millions of dollars, like we mentioned before. And like I said before when I first started this, that education is key to preventing a VAP, and that all healthcare workers, from experienced nurses to new grads, need to be educated and re-educated to assure that VAP prevention is in the forefront of our care. And then we want to take that one step further by making sure that we are educating our patients and our families about VAP and VAP prevention because it is vital to their outcomes. And then the ventilator bundles that we set forth in that the CDC and the IHI have shown, they have been shown that they can reduce the risk and incidence of VAP. And then healthcare workers need to make sure that we are adhering to the ventilator bundle because it is critical to preventing the VAP and preventing, making sure that we have better outcomes for our patients. So there are many methods that we can be used to improve compliance in our facilities, such as the audits and the yearly checkoffs and things like that. But the most important thing also besides just the education about VAP is making sure that we're also learning more ways that we can prevent VAP because the more we learn, the better we are to be able to fight VAP. And then for our interactive piece of this, I have made a little crossword puzzle that if you guys want to go and further your education or to quiz yourselves on what we have taught y'all, you can go. It will be underneath our presentation and we will make sure that you guys know everything by taking this crossword. And then let me go back. And then this is our references, and then Sadie.
We believe that based on our research, if nurses are able to comply with the interventions that we stated and they are up to date on their education and they follow through, that ventilator-associated pneumonia can be prevented, costs can be down for patients and hospitals, and it's just one less thing to worry about for our patients and the hospital staff.
Only you can prevent VAP.